Healthcare-onomics, changing healthcare by changing the way you think about healthcare. All right, welcome to Healthcare-onomics, where we're here to change healthcare by changing the way you think about healthcare. I'm Dr. Kevin Wacasey. I'm the founder of Healthcare-onomics, and I'm a direct patient care advocate and practitioner. And we're here today talking with Dr. Lee Gross from Southwest Florida on some recent updates in Congress that have gone on with a bill that's affecting direct patient care and the outcome that's likely to happen from that bill. Dr. Gross is a founder of Docs for Patient Care Foundation, and he is he's the president of the Docs for Patient Care Foundation, and he is the founder of Epiphany Health and direct primary care practice in Port Charlotte, Florida. Welcome, Dr. Gross, and thank you so much for your time this evening.
And thank you so much. I appreciate you having me.
Well, why don't you give us your website and some contact info in case anyone's interested in speaking with you?
Sure. So our website for Docs for Patient Care Foundation is www.d4pcfoundation.org. And then, of course, if you want to learn more about direct primary care, you can always look at my practice website, Epiphany Health, EPIPHANY health.net. And we have lots of great information for folks that want to find us. But really, if you want to find information about direct primary care, conferences that we put on, educational materials, it's all available at the Docs for Patient Care Foundation website.
Great. And I think you'll agree with me that direct primary care, or as I like to call it, direct patient care, is the future of medicine, the practice of medicine in the United States. I think that it's going to take off and it's going to be big. The question is, how is it going to be affected by congressional, let's say, interference, for lack of a better term, and how's it going to be impacted by patients as well as the health insurance industry? And you've spent quite a bit of time in Washington, D.C. discussing these matters with congressional folks and even with some folks from the Oval Office, if I'm not mistaken, correct?
That is true. We have talked with everybody in Washington, from Congress to the White House to the Treasury Department. There's no shortage of people in Washington that are interested in getting their hands on this particular issue. It's fascinating how this has sort of developed over time. So I think we'll kind of sort of explore that over the course of this conversation. But
yeah. Now, isn't it interesting how the federal government, and let me just backtrack a little bit and say that you and I met across Twitter. I started my Twitter career about 1.5 years ago. It has been amazing for me. It's been my psychotherapy. I call it my mistress because I spend a lot of time on Twitter preparing tweets and reading tweets and responding, etc.
You are the king of snark.
Thank you. I appreciate that. I'll take that. But I will say that, well, what can you do? I mean, this situation is so ridiculous. It's so crazy that, I have some terms I coined. Anti-sense is one of them. Healthcare in the United States, especially more specifically the practice of medicine, is so just crazy that it doesn't even rise to the level of nonsense. I call it anti-sense because people, well, for instance, most of the people watching this wouldn't let a company tell them what to put on their pizza tonight. And yet most of the people watching this will let a health insurance company tell them that they can't see you or I as their doctor anymore. Now that's just nuts. I mean, that's crazy. That's anti-sense. We don't allow that to control any other aspect of our lives. And I think the vast majority of this is due to congressional interference and Congress sticking its nose where it really doesn't belong, and that is into the physician-patient relationship. And that's what this whole podcast here is about tonight. It's to talk about what's going on with this new thing called direct patient or direct primary care. Now, for our listeners, can you just tell them what exactly that definition is of direct patient or direct primary care?
Well, it's interesting that you use direct patient care because that's actually something that's important in this legislation, because historically, the phrase has been coined to direct primary care. And in fact, right, direct primary care has a legislative definition now in 25 states. And that definition basically defines a contractual relationship between a doctor and a patient as not being health insurance.
Right.
So the concern all along was if a doctor and patient contract together for a flat monthly fee, which is basically what direct primary care is, which is a membership-based primary care, much like Netflix. And you can, join your primary care doctor's office and binge watch on all your favorite episodes. You can join your primary care doctor's office and, binge on all your chronic medical needs without any additional charges. So that's what the direct primary care is. The concern legislatively is that if you are selling services for a flat monthly fee, then you should be a risk-bearing entity, and that risk-bearing entity should be regulated as an insurance company. And so, we have been successful, and I say we collectively as a group of direct primary care doctors and supporters, at passing legislation that protects this practice of medicine in 25 states.
Right.
So that is a huge accomplishment in itself, which brings us to other regulatory issues. So you may not know that direct primary care is the only medical practice, the only medical service in the country that you can't use your health savings account to purchase that service. So you can go anywhere with your HSA as long as it's not paying for a direct primary care membership.
Yeah, isn't that interesting? You can get your physician to prescribe you Band-Aids or Vaseline, is my understanding, and you can cover that with your HSA. And tell us, real quickly, tell us the benefits of what an HSA is and why it's so important.
Yeah, so basically an HSA allows you to use pre-tax dollars to purchase your membership. So it gives an individual the buying power as if they were purchasing, say, a group health plan. Using, a company can use pre-tax dollars to buy a health plan, but an individual can only do that really through a health savings account. So it just increases and extends the buying power of the individual.
Right.
And as deductibles now are higher and consumers are having to shop for themselves, they need to make their dollars stretch as far as possible. So these health savings accounts are really important vehicles.
They need to take advantage of every possible opportunity that they can to save on their health care, because now remember, one of my big things, my big pet peeves is that I like to separate out health insurance from health care. I mean, the two are totally separate and distinct entities, and all too often in the media they get thrown and jumbled together, but we have to be careful about keeping them separate. But what's really interesting and what's ironic to me is that it seems like Congress and the legislatures across the states, in the various states, are trying to do that at the legislative level. They're taking health insurance and health care and they're melding them into one, and that's where we get this whole idea that direct primary care, or really care that you pay for in this membership model type scenario, is health insurance. It's some kind of a risk management tool. I strongly and vehemently disagree with that, and I know you do as well. And I think it's a bit of a stretch for anybody to come up with that kind of a label. And it makes me curious. Okay, so I'm not a conspiracy theorist, but I do live in Dallas, and I've been to the grassy knoll, and I've been to the museum, and I've seen everything, and I don't think Oswald acted alone. But I'm just saying that, hey, I don't believe in Martians, but I don't believe in Congress really doing what's good for the country either, as opposed to doing what's good for themselves in the face of lobbyists, etc. So would you care to talk a little bit about why you think the big push is on to box direct primary care in, as Congress is trying to do?
I can certainly give my personal opinion. It's always about control.
Yeah.
I mean, at the end of the day, when it comes down to physicians, and I don't want to let insurance companies off the hook. I mean, we're focusing on government in Washington, but the insurers are not innocent innocent parties here in this whole thing, which we could spend an entire podcast on that as well. Right. But yeah, it comes down to control and dollars. And so once the insurance companies lose control of the physicians, it's, I think that is a big fear of theirs. And so, and then at the end of the day, if something's not logical, then follow the money.
Right. Right.
And so, what I've seen Congress do is take something that should be extraordinarily simple and make it extraordinarily complicated. And there are very few reasons for them to have done that. So I'd love to just sort of get into the details of the bill, why we got here.
Yeah, sure.
What exactly the problem we're trying to fix was, and so why did we even get to this situation? Because nobody in their right mind asks Congress to regulate them or to legislate over them. Yet we've been going hat in hand to Washington asking for some help,
some reprieve.
So, what exactly is that? We talked a little bit about the HSAs being used for direct primary care, and I'm going to use DPC for short.
Yeah.
For DPC, so the issue, it all goes back to 2014, when a fellow by the name of Koskinen, who was the IRS commissioner at the time, wrote a letter saying that direct primary care is a health plan, and therefore, if you have a health savings account, you already, by definition, have to have a compliant health plan. Therefore, direct primary care would be a second health plan, and a second health plan would disqualify the health savings account. Therefore, anyone with an HSA that even joins a direct primary care practice, not uses their HSA dollars, but just as much as joins them, will disqualify their HSA and not be able to contribute to it.
You're kidding.
So that, yeah, well, this was an IRS commissioner at the time that was really trying to prop up the Affordable Care Act marketplaces, trying to steer everybody into that vehicle, and anything that may have been driving some traffic away was going to get shut down. And so we were victims of a landmine that was placed directly in front of our feet with the intention of sabotaging it. And so this was 2014, and that one letter has defined the direct primary care legislative problem ever since. And so this letter has basically become law, regulation, through letter, not through Congress. And so, the issue that we continue to have when we go back to Washington is, there is nothing in the law that says that memberships can't be paid for by HSAs. It's just this letter. And
you mean there's nothing in established law as written by Congress and passed by Congress that says this? Or are you talking about administrative regulations now?
Both.
Okay.
Either. And so the issue that we kept bringing to the White House and to the Treasury is, why do you need law to trump letter? Why can't a letter trump a letter? And so, everyone continues to point their fingers and say, we recognize the problem. We want to fix the problem. We agree with the problem. We agree that it should be fixed. Let's let Congress fix it. And you and I both know Congress couldn't fix a flat tire, let alone, something this simple.
A friend of mine said, just briefly, a friend of mine once said that, you know what a turkey is? It's an eagle designed and implemented by Congress.
Exactly.
So, yeah.
So there was a piece of legislation out there, and we'll start getting in the weeds now. It's HR 365, House Resolution 365, and this was a bipartisan sponsored bill. Had 38 co-sponsors, had been around for a long time, but had not moved anywhere.
Right.
And this was a very simple one-page fix to the issue. It's called the Primary Care Enhancement Act. It solved all the problems that we needed to solve. And again, it just sat there dying on the vine. It never moved out of committee.
But what exactly did that bill say? Just give us a nutshell of what that bill said.
In the nutshell, it basically defined direct primary care as a qualifying medical expense.
So that you can use your HSA to pay for it.
Use your HSA.
So in other words, patients can use their pre-tax dollars that they've contributed into an HSA to pay for their doctor visits, basically. Okay.
To pay for their doctor visits in a membership model.
Right.
And so, again, this bill sat forever. All of a sudden, last week, out of nowhere, this bill pops up in Ways and Means Committee. Ways and Means is pushing a big HSA reform package, and this bill that is being defined as a revised 365 comes forward, completely changing the entire situation. It is in a brand new bill. It's a 5-page bill,
as opposed to one page.
As opposed to one page.
Yeah.
The bill number changes. If you're keeping score at home, it's now 6317, House Resolution 6317. And when we saw this bill, basically the day before it was going for markup in Ways and Means, it blew our mind what this bill did. And we'll get into some of the details of it. But
now, I don't think it was a coincidence that this thing came about the day before they were supposed to hear this in committee, correct?
Right.
Yeah.
And so in our conversations with the offices involved, the vote had already been cast before the bill even saw the light of day. I mean, this was sort of a pre-negotiated. The terms had been settled, and as far as they were concerned, this was a non-issue. This bill was going to pass, and it quickly passed out of Ways and Means, despite vigorous opposition by the independent direct primary care physicians.
By those that would be impacting, yeah.
Yeah. So that's an important distinction, because you have the independent DPC doctors, which are solo 1 to 3 provider practices that contract directly with their patients, maybe some small businesses. That's about 95% of the DPC practices in the country.
Then you have
and then you have about 5% of the practices, which are large corporate entities. They go to big businesses, 500 to 1,000 employees, state of New Jersey or other places, and say, we're going to contract with you for direct primary care services. Then they go around and sub out the primary care work. And so they basically hire up their primary care doctors, they sub out the primary care doctors, but really the relationship sort of goes through an intermediary broker.
I've said that before. To me, that's not really direct primary care. That's a corporate practice of medicine model whereby instead of using health insurance, they're just paying for it directly. But nevertheless,
and that's who this bill was written Okay, and so you have a bill that defines direct primary care that affects the 5% of corporate practices and protects them while being detrimental to the 95% of
Are you
practices.
kidding?
I'm not kidding.
Wow.
uh,
Okay, I did not know that.
yeah, so that's
Okay.
the direction that this goes, and so um, I guess we'll kind of get into the weeds a little bit if you don't mind, just sort of
Yeah,
hitting some
sure, sure.
I would call them the high points, but we'll call them the low points of the legislation. And I guess the first thing, of course, that stands out is that they put a cap on what a physician can charge. And so for the first time in history now, we have a federally legislated wage cap on primary care services. Uh, there,
And just to clarify, this is the amount that they can charge per month, right?
this is the amount they can charge
It's
per
set
month.
at $150. So in other words, a physician can't charge a patient more than $150 a month.
Right.
Okay.
And so, their argument is that, well, that's more than most people are charging. That's not the point. Um, the point is, who is it to determine what's a fair price, and why are they setting the physician wages? And what's to say that let's pick the insurance lobby. The insurance lobby won't come back now that this thing passes and push that down to $50 because they're trying to squeeze out somebody. So once you get that on the books, there's no saying what lobby is going to get their hands on this in the future and modify. And imagine the precedent to use federal wage controls to bring down the cost of healthcare services. So
I think it was
Sorry.
federal wage controls that got us in this health insurance business nightmare to begin with. But that's a whole nother podcast. But go ahead.
Yeah, you are absolutely correct. So that, and I think, the feedback that I'm getting is they think that is the biggest problem that we have with the bill. That is not the biggest problem. It's a problem, but I concur that price point is one that is not going to be an issue for most of them. It's just the general concept of, again, sort of federally price setting this.
Setting an arbitrary value that has no basis in reality other than just toss a coin.
That will be changed whenever they're looking to save money in the future.
Right.
And again, setting up the practice. If I charge fee for service for primary care, there's no cap whatsoever on what I can charge.
Right.
If I'm a hospital, there's no cap whatsoever on what I can charge. If I'm selling Vaseline, using your example, there's no cap. You can buy an unlimited quantity of Vaseline with my HSA, but they're saying what the doctor is limited to charge. So it's a big part in theory, but in practicality, probably not the largest issue. The largest issue is in their definition of direct primary care. And so in their desire to stop the direct patient care that you described, they only want primary care doctors doing this. So they do not want specialists in any way, shape, or form even attempting this. So legislatively, they've carved them out. And it specifically states it's for primary care. But then they go on to use a definition of primary care that is so narrow and that it kind of almost carves out primary care from primary care. I kid you not. I mean,
This ought to be great.
So first of all, what they did was they used the Affordable Care Act's own language of definition of what primary care is. And so again, they're pulling Affordable Care Act created code into this. And this is where it starts to get into the weeds, because if you look at the actual language of the bill, it doesn't look too intimidating. If you follow the links to the codes that they reference, this is where this bill starts to fall apart. And so when you follow the code, follow the dotted,
Right.
follow the bouncing ball, you follow the bouncing ball to the language it references and see how that affects the language of the bill, that's when everything falls apart. And so they use words here like solely, where they're saying that primary care practice can solely provide services in their contracts that are included in these CPT codes, which as you know, I see by the eye roll there.
Yeah.
The CPT codes are what direct primary care doctors they escaped from. So you can provide medicine without providing the coding.
Right.
So what they've done is they've tied the direct primary care definition to provision of these certain codes, which are the only things that can be included in your membership agreements. And for you and I, those codes are your evaluation and management codes, your 99211 to 213 codes.
Which are for office visits, basically.
Which are for office visits. Yeah. No testing, no procedures, no nothing. So no ear washes, no urinalysis, no strep test, no blood glucose checks, all the stuff that we do in our office all day, every day.
Wait a minute, and let me see if I get this correct. You're saying that that's excluded from primary
It has
care?
to be by the bill. It can't be included in the contract. Okay, it has to be excluded. Okay, right. So what does that mean? Okay, so let me give you two more things that are not included in those codes that are allowed to be bundled into the agreement: wellness examinations, pap tests. So now we're excluding women's wellness care from primary care services. It blows my mind how they can, use such a narrow definition. And so the supporters of the bill are saying, well, you can work around this. Just go ahead and have your office visits in part of your contract, and then you can go ahead and have separate fee for service that you can do for things outside of it. So you can bill extra. Well, we bundle all that stuff into our services. That's why our practices
part of what makes
successful.
it attractive, yeah.
Part of what makes it work is that we don't nickel and dime for everything. And so their counter argument is, well, you can keep it outside of the agreement, but still make it a zero price tag. You could still provide that service outside of the agreement, but charge nothing for it. And so the logic that I'm hearing is it's unenforceable. Therefore, we should support it because the penalties are unenforceable. I'm hearing that you won't need to code unless there's a retroactive look back period, in which case, boy, you're going to really wish you had coded that all along to prove that you weren't bundling these things into your contract. So again, it starts to fall apart at this. Then it goes on to try to really put a wedge between the direct primary care doctors and the concierge physicians that charge kind of twice. They charge a membership fee and they charge for fee for service.
Right.
Congress doesn't like that. They don't want HSA dollars to be used for that. And so what they have done was they've said your sole income has to be from the membership.
Wow.
Okay.
Wow.
Now we have start to see some influence from the pharmaceutical lobby in here, and they have specifically carved out pharmaceuticals from being included in the contract. And so for you and me, that means injectable steroids, that means injectable antibiotics, it means an anti-nausea medication for somebody that's vomiting in the office. All that stuff, again, that we, most of us bundle into the practice, now has to be excluded from the contract, billed separately, or filed with your insurance. As you know, a lot of direct primary care practices do wholesale pharmacy in their offices. Not clear how that, you must exclude pharmaceutical from your direct primary care practice in order to be HSA eligible. So it creates so many shades of gray and uncertainty. So here's the worst part about this entire bill is.
Oh, it gets worse. Great.
Oh no, I mean I know it's good so far, but it gets better. It doesn't fix the problem. Yeah. They fixed the wrong legislative language, and so instead of saying like HR 365 said, direct primary care is a qualifying medical expense, boom, end of story. What they've said is that direct primary care is a qualifying health plan that is eligible to use for health savings accounts. So it defines it as a health plan.
Not as health care, but as health insurance.
Not as health care, as a health plan. And so what that means is that sets up conflict with all of the states that have said direct primary care is not a health plan. Okay. So now you have the IRS that says it's a health plan, and all half the states in the country say it's not a health plan. Now, what you've done by instead of declaring it to be not a health service but a health plan, you've now created conflict with using flexible spending accounts, with health reimbursement accounts, which really weren't an issue now, but will be an issue going forward with with the new legislation, because now it's not a health expense anymore; it's a health plan. And so it's created one gray area of loophole created by a single letter by a single individual that was trying to prop up a failing law. And they're fixing it by creating 10,000 additional levels of complexity, micromanaging, practice, reintroducing potentially coding into practices that have escaped coding, put salary and wage caps, and they're expecting us to be happy about this because it's not a perfect bill, but hey, it's better than nothing. Quite frankly, I think nothing is probably better than this. And the I've been doing this since 2009. So status quo since 2009. It's a hell of a lot better than what I see in this potential legislation.
I'll tell you who ought to be angry the most, and that is the patients. The patients are, of course, the people that I'm trying to reach. They're the people you're trying to reach. I think that educating folks is the way to go as far as changing healthcare these days. We need to educate physicians as well as much as possible, but the patients are the ones who ought to be the most ticked off about this, because the whole effort behind the direct primary and direct patient care movement, and the way I would define that is rather simple, and that is no third party involvement. Direct patient care to me means that it's me and my patients. It's physician and patient. There is no third party payer. There's no third party regulator, aside from the state licensure boards that we all have to deal with. But other than that, once I've passed their exams and passed all their rigmarole, I'm good to go as far as I'm concerned. And the patients can see me or not at their whim. And that's a free market based type scenario where the practice of medicine is back to where it was in my childhood when, my mom took me to the pediatrician. She wrote a check for the visit. So the health insurance encroachment further and further into the healthcare stuff started to slip with the introduction of high deductibles. I wrote a book called The Guide to Buying Health Insurance and Healthcare, and in the book I maintain the entire premise of the downfall of the health insurance industry is the fact that they've got high deductibles now. Because if patients are having to pay for the majority of their health care, especially their routine primary care, then they don't need health insurance anymore. At least they don't need it to pay for all their care. In fact, they can't use it to pay for all their care. So, and
Right.
I'm sorry to rant, but here's one thing that I really like to harp on. A lot of my Twitter colleagues, physicians, like to point out that we have a prepaid healthcare system these days in our health insurance industry. No, that's not true at all. It was prepaid healthcare with $5 copays and $200 deductibles. Now with $100 copays and $5,000 deductibles, now it's really more of an insurance product. So they've let slip their grasp on the practice of medicine, but now that direct primary care has come along and has made inroads into that hole that they've left open, now they're coming back through with Congress's help and snatching up control of it once again. So to me, again, to make my point very clear, the patients are the ones who are going to suffer the most out of this, because life's going to go on for us docs. I think that most people who want direct primary care are going to pay for the added benefits of it, having a physician on 24/7, having somebody at your fingertips that you can reach out and talk to anytime you need to, no appointment times, no waiting, no taking off work for a day to get off to go see the doctor. I mean, there's a lot of benefits in that, and the patients who are paying me, at least, are the ones who are, they could care less whether the HSA is involved or not. If it is, it's good, and there's icing on the cake for them. But I think this not letting the HSA be used really takes the ability for a lot of other people to take advantage of something like direct primary care. If they have HSAs, they're putting the money into them anyway, or like you said, flexible spending accounts, or even if they have HRA benefits under their insurance plans, they're not going to be able to use that with direct primary care, and that really stinks. So they ought to be really up in arms about this as well, I think.
I couldn't have said it better myself, and I think the challenge I get into with dealing with Washington is they think it's their money. And what they don't understand, it's the patient's money.
I'm sorry for all the eye rolls. Sorry.
Yeah.
I have no other gesture that I can give it.
And that's the challenge, because we're looking at the CBO scoring on these bills and how much money it's going to cost the government to allow patients to keep their own money, which is, those numbers are based purely in fantasy.
Yeah.
Just putting that aside, it's the patient's money. Let them have their money and let them use them. And so, the whole point of the HSA is to allow market forces to allow patients to be smart consumers and to make good decisions on how they're using the healthcare dollars. That is the exact reason for it, the exact reason why you don't need federal wage caps. Because if it does not have value to the patient, they're not going to spend the money on it. It's their money. So, again, totally defeating the reason for that.
Well, I like to point out that what's it worth to a patient to see me? It's worth whatever the market will bear, and or it ought to be worth whatever the market will bear. And so what they're doing now is they're setting an arbitrary limit on this at $150 a month. And I'm not saying that's too much. I'm not saying that's too little. I'm saying that as long as you establish that kind of arbitrary and capricious limit, well, who knows where it's going to go from there. Like you said, once the other lobbies start getting a hold of this and creating law through just administrative regs. Let me ask you this, though. Let's say that a patient doesn't use their HSA to pay for the direct primary care. Does this bill affect them or you and I as direct primary care providers at all?
It does in the fact that, if I'm a direct primary care practice and I choose not to comply with these regulations, then patients that come to see me are going to pay a 30% tax premium for the privilege of seeing me over the corporate DPC doc that is complying with all the rules. So my prices will be taxed, and theirs will not be. So again, the large corporate taxes will have an unfair advantage,
Sure.
which is exactly what drove the consolidation of independent practices to begin with.
Right.
The cost of compliance was too high, and so the independent practices had to close shop and sell out to the large hospital chains and corporations.
Right.
So if we now put a regulatory burden on the small independent DPC practice and steer patients towards the corporate practices because they can be HSA compatible or HSA compliant, then it puts the small practices at a massive disadvantage. So the doctors are harmed by it. The patients pay a premium to see the independent docs over the corporate docs. So it affects you whether you accept the HSA patient to your practice or not.
But I guess my question is, if you choose not to use, if a patient chooses not to use their HSA, then I guess there's really nothing the feds can do to you at that point, other than the financial hit that the patient's taking and the competitive hit. But there's nothing directly. Nobody's going to come out and arrest anyone or fine anyone as long as the HSA is not being used. And I guess what this creates.
Let me correct that. So if nothing happens, if no bill passes and we stay with the status quo, if the patient has an HSA and they join a DPC practice, whether they use their HSA funds or not, it disqualifies them from funding their HSA and using their HSA to pay for anything whatsoever. So that's continues to be a problem whether this, if this bill does not pass. And so, that's why this is so difficult in that, frankly, this bill is better dead than alive in its current incarnation. But
Absolutely.
dead basically is also handcuffed to the growth of the DPC movement. But alive, this bill is going to choke it out anyway. So
I went to. Go ahead.
Walk the plank slowly or walk it fast. I don't know.
Yeah. Well, I went to law school. I didn't finish law school, and I'm not an attorney, thank goodness. I didn't have the ethical makeup that it takes. Just trust me on that one. But I did take contracts and a fascinating class, fascinating experience, law school. But one of the things I'm quite aware of is how they can take these laws and regulations and then use them for unintended consequences later. So I can imagine that what this law is going to do also, whether we know it now or not, it's going to put a burden on physicians, DPC physicians, to put in their contractual language that, hey, look, you can't use your HSA. But not only that, if you join my practice, you can't use your HSA for anything. And if a physician fails to do that, then it's quite possible that physician could face, who knows? I mean, you know what Medicare does to physicians who don't play by the rules. They start reaching into their personal bank accounts, etc. So I don't know what possible consequences could or would occur if, let's say, you're a physician, you're doing DPC, but you fail to adequately warn the patient not to use their HSA, to go buy some Vaseline or some Band-Aids or what have you. They go and do that. Now you're going to be on the hook. Perhaps the patient's going to get in problems.
Well, I think the patient, it's more the patient that's going to get in trouble. And I think your point of not duly warning the patient that this disqualifies their HSA is some liability on the practice. I mean, but ultimately it's the patient that pays the penalty. Which goes back to your previous point. It's the patients that get harmed in this entire process.
It's insanity. It is insanity. So let me ask you this: can you name some names for us and tell us who's behind these changes to the bill?
We're still working on that.
Okay, I got you.
We're still working on that. This is a work in progress.
But it is the House Ways and Means Committee.
House Ways and Means Committee.
What was the final tally on the vote?
I think it was 24-12. It was a narrowly bipartisan. So
Okay.
A few Democrats broke and voted with Republicans on this one. Most of the HSA bills were along party lines. So, and the fact that it did garner some bipartisan support speaks to the popularity of direct primary care.
Right.
The original bill had 38 sponsors from both parties. So But this bill doesn't resemble that bill in any way, shape, or form.
Now, how many
So
members are on the Ways and Means Committee? 30.
you do the math. It's in the
Okay,
30s, yeah.
30 something. And so you're saying 24 voted to pass, 12 voted to nay, voted nay on the bill.
Yeah.
And so where does the bill head next? What's its legislative history after this?
Yeah, it's going to probably go to the Rules Committee, which I think it'll fly right through. And then ultimately, what I suspect is going to happen is it's going to get bundled into a large one single HSA bill that goes to the floor of the House and is voted on as a HSA reform package. So the question is whether or not the DPC bill will be included in that larger reform package or not. And then it's off to the Senate,
Off
where
to the Senate, yeah.
they can decide what they want to do with it. They can pass their own version. They can modify this. Take it up and pass it. I suspect they'll probably want to do their own thing, but
Now, how soon do you think this will happen? I mean, just can you give us a timeline? Do you think this will? Because this bill did sit in that Ways and Means Committee for years, if I'm not mistaken,
yeah,
before it got acted on, and now what's flying out of there is not anything resembling what was originally proposed. Do you think they might accomplish this legislative session, getting it over to the Senate?
the House will pass this before the August recess.
Okay. So then
Yeah.
we have some limited time in which to act. So I think everybody needs to throw a fit about this, from employers groups. Obviously getting the word out is important, but the people most impacted by this are those with HSAs or even flex spending accounts. It sounds like anybody who puts pre-tax dollars into their employment or through an account with their employer to pay for their health care needs to be outraged about this.
Or people that value making their own personal health care choices.
Yeah.
Because this is truly one of the last opportunities to have healthcare freedom and the ability to choose your own healthcare and who you choose to have it with and what services you decide you want and don't have somebody else telling you how to do it. And so, if you value your healthcare freedom, this is certainly something to be concerned about. And if you like the direction of the direct primary care movement in terms of there's no reason to use insurance for primary care services, and we should make routine care affordable for absolutely everybody and make it cheaper than the cost of your cell phone. Then you want to continue to see this direct primary care movement grow. You want to see specialists incorporating it, pediatricians, and the like. And so you can't this early in the movement completely distort and disrupt what's going on, unless that is the intent of this legislation, in which case it should do it just fine.
I would hazard a guess that is exactly what it's intended to do. Of course, I am a cynic, and I'm a conspiracy. Am I a conspiracy? Yeah, I think I am a conspiracy guy. More and more
I think
every
we've already
day.
established that. That's one thing.
Well, I mean, I tried watching MSNBC the other day. It did not work well. So, I mean, conspiracy theory. So a little bit more about this whole process of. Let's talk a little bit more about direct patient or direct primary care, though, because to me it does represent the most simplistic return to normalcy, really. I have this story that I like to tell, and I repeat it often, but I think it's worthwhile repeating here. I got called a genius at a concert a few years ago by a woman who asked me what I did. And when I explained that I had a clinic and I didn't accept any health insurance from my patients, she said, "You're a genius." And I said, "Well, I'm not really a genius. I mean, my business model is like every other business in the U.S. I provide a service and I get paid for it. What's genius about that?" But what's really genius, lady, is the fact that you think I'm a genius. Now that is genius. And she thought about it, and her husband thought about it, and I think very quickly they came to the realization that they've been had for the past several decades, virtually their entire lives, because here were people thinking that you had to have health insurance to have any health care. And, high deductibles, to me, ought to be the biggest clue to people that, look, you can have health insurance, but that doesn't mean you have health care anymore. It's not about a $5 copay if you have a $10,000 deductible. So that ought to be the biggest clue. And that is the biggest clue for people who pay attention and people who learn that lesson. But what's filling that gap is direct primary care. And it's a very nice way to fill the gap. I mean, I like to say that a DPC membership or a direct primary care relationship with a physician and an HSA, a health savings account, all that plus catastrophic health insurance coverage, because let me be clear, I do believe in health insurance. I think health insurance is a great thing to have. It's very wise, but it's not something that you should use very often. We should hardly ever be using health insurance. But having all three of those things You can not only save a ton of money, although the availability of catastrophic coverage is very limited these days, but I predict that that'll change if we can break Congress's hold on it. I think having those three things is the best kind of healthcare coverage one could possibly have. And the fact that they're trying to monkey with this now, it just drives me crazy. It makes me so angry. And like I said, it ought to make every American angry that they're sticking their nose where it really doesn't belong. And no other industry would tolerate this. I mean, let's face it. No, I hate to.
But healthcare is different.
Healthcare's different. Yeah, I know.
It's different. The economics don't work. So the first time I went to Washington and presented this to a group of people, and I think at the time I was charging $83 a month. I had to, because of the skyrocketing cost of healthcare, I had to lower my price to $60, over the last almost decade. But the question was, if you're charging 80 and somebody sets up next to you and charges 40, what are you going to do?
Well, in a free market, I know what I would have to do.
I said, if the first question out of the audience is, what are we going to do when we actually are effective at lowering the cost of healthcare, then I think we're onto something. But what we're going to have to do is do something crazy like compete on price and quality.
Yeah.
And then, God forbid, let the patient decide whether they're getting a good value for their money or go somewhere else.
Yeah.
And I may have to lower my price, or he may raise his, or we're going to come up with something that works, that allowing true market forces, not the price fixed competition that you see in the current crazy system, but true market forces to allow to establish what the value of these services are.
Yeah, I was going to say people get scared about $150 a month and $100 a month, $75 a month. That's a lot of money, and I make the point in my book that I know of a service I saw. Literally, I really did see this, a poop scooping service. One day on the road, a truck passed me, and I was pretty shocked. I took a look at it, and I couldn't believe that what I saw in there in big, rather brownish letters, that we scoop your poop. And so I went home and looked it up, and sure enough, there was a franchised outfit. It's got locations nationwide, in the affluent areas, mind you.
I must have started in Washington, D.C., right outside the Hall of Congress.
And they're going strong, believe me.
Yeah, business is good.
They must charge a lot more than these turkeys do, because these guys are charging $15 a week. But that's still, when you add it up, that's $750 a year to do something that I made my teenagers do when they were growing up. Hey, they wanted a dog. But bottom line is that people will spend the kind of money on things that they see value for. And when they think about healthcare, they don't know how to value it as of yet. Most people don't know how to value it because they're used to paying health insurance premiums and having all the healthcare that they want handed to them. Again, with high deductibles, that has radically changed. That's not going to change back anytime soon, if at all, if ever. And so you better get used to it, America, that you have to pay for your healthcare now. And I can think of few better ways to do it than to establish a direct primary care relationship with a physician who it's not only cost affordability. I got to tell you a story just really quickly, and you can tell me one of your success stories. New Year's Eve of this year, 2017 going into 18, I'm at a party, not drinking. I don't drink very much at all, but I'm at a party, and one of my patients texts me at 11:35 p.m. says, so I call him back. He says, I'm so sorry to bug you. Oh man, I don't mean to bug you. I'm like, hey, no problem. That's what I'm here for. That's what you pay me for. What's up? He explains that he has this left lower abdominal pain that he's never had. He's in his mid-50s. So after a few pointed questions, I'm able to pretty much diagnose him over the phone and say, look, I think you have what's called diverticulitis. I'm going to prescribe these 2 antibiotics for you. I want you to go get them now, before the stroke of midnight if you can get in there. But you need to start taking them before you go to bed, and then I'm going to contact you in the morning. And if I need to see you in the office tomorrow, I'll bring you in on New Year's Day. And if not, then I'll see you on Tuesday, on January the 2nd. Well, contacted him the next morning. He had gotten the antibiotics. You know the rest of this story, I'm sure. I saw him in the office on Tuesday, and the only bad thing that happened to this gentleman out of that whole experience was that he finally understood that he really needed to go get a colonoscopy, because he was like 56 and he'd never gotten a colonoscopy. So this hurried up his whole motivation to go and do that, and it was fine, actually. He had a little diverticulosis, but you know how much money I saved that guy? I'll tell you this, he is a builder. He's a home builder in the local area here. So he's not a slouch, but he has health insurance, but he has a $12,000 deductible plan with his wife. So you could say that I saved him at least 12 grand with that one visit. That's what direct primary care does. That's the whole goal of what we're trying to do, is to save people money, to provide them with excellent service, and to give them quality health care, quality medicine, in what we can do. So, you have any stories that match that? I'm sure you do. You've been doing a lot longer than me.
Oh, no, I've got a whole bunch of them, but yeah, it's, we've seen our first case now of inbound medical tourism from out of the country for
Wow.
affordable medical care, because for us, it's all about quality and value. It's
Sure,
about
sure.
I mean, it starts with the relationship, but from them, it's quality and value of the medical care.
Sure.
So we don't just stop seeking value within our practices. We go outside our practice and try to negotiate discounts. So for today, this afternoon, just before we got on the line here, as I negotiated my second hospital for bundled surgical pricing for patients with no health insurance.
Wow.
So we now have our first and second hospitals in the country that have agreed to cash bundled prices in advance
Wow.
for inpatient surgery. So you've probably heard of Surgery Center of Oklahoma.
Oh yeah. Yeah.
We're matching their prices in the hospital, in 2 hospitals now in Florida.
Wow.
We actually had a patient that we co-managed with Keith Smith and Surgery Center of Oklahoma. Patient was in Antigua, Caribbean, and she had thyroid cancer and she needed her thyroid removed, and she they were quoting her about $100,000 to have her thyroid removed in San Juan. And so she got in touch through her physician with Keith Smith and Surgery Center of Oklahoma. And Keith said, sure, we'll take out your thyroid, but the problem is that you need 6 months of preoperative and postoperative medical management. You need pre-op workup, you need staging, you need blood work, you need an endocrine consult, you may need radiation. And so Keith picked up the phone and called me and said, Florida's a lot closer to the Caribbean than Oklahoma City. Do you mind doing the medical workup? And so we agreed to do it. Patient came in, got a 6-month medical visa. We saw her, packaged her all up, coordinated it with Oklahoma City. She went out there, had her cancer surgery, came back, did amazing. And take a stab at what the total cost was, $10,000.
Wow. Wow.
So
versus $100,000
versus $100,000.
without all of the ancillary stuff that you were providing.
Right. And so, at $100,000, the conversation is you're going to die of thyroid cancer.
Sure.
And,
sure.
At $10,000, it's, my goodness, that is a heck of a lot of money. We're going to have a bake sale. We're going to get the church together. We're going to go around the community. We're going to wash cars. We're going to pull out the credit card. But it's not, a death sentence.
Right.
And so,
Right.
like I said, we're now doing that in Florida. So we're seeing patients coming to us from across the state of Florida for the types of ancillary discounts that we're able to get for patients in our program. So from massive discounts on imaging services, laboratory services. So speaking of making your HSA dollars travel further, for us taking $100,000 surgery and taking it down to 10 grand, that's certainly an extension on using your HSA dollars. That so if you're a self-funded health plan, which I think most large businesses nowadays, if they're not, they should certainly be considering something along those lines.
Sure.
These are real dollars that affect real people, and this is this money's coming directly out of employees' wages.
Yeah.
So that $90,000 that wouldn't have happened with this, this one person in the Caribbean is $90,000 that would have happened if this patient had a plan that had to absorb that cost. And so when we negotiate those prices up front from them, the self-funded plans get those same discounts and same arrangements that we get for our patients. And so, again, more reason to incentivize these patients to go to the direct primary care practices to continue to expand the value proposition that the DPCs offer. Also, the main reason. Yeah, go ahead.
I just can't imagine how evil people must be in trying to put the lid on this, trying to keep this boxed in, and it's a special kind of hell that I hope exists for anybody who's at the congressional level who votes for this. And who says that, yes, we want to box this up, we want to constrain it even more, we don't want patients to break out of this restrictive, reactive healthcare system that we have.
I'm going to go ahead and give them the benefit of the doubt on this one. What I'm going to say is that they had heard our concerns that HSAs were not compatible. In their own special way, they wanted to help us. And the special interests stepped in and steered this process in a dangerous way. But I think the original legislative intent, I think, was pure.
Yeah,
I think
yeah,
they
yeah.
perhaps were misguided by some people that really supported this, this 5% of practices that really work largely with employers and not with individuals. And may have sort of misrepresented that they were speaking for all DPC practices in general. And let me be clear, I don't speak for all DPC practices in general
I
either. This
understand.
is my this
Sure,
is my opinion.
sure, sure.
Uh, but it's my opinion from a guy that's been doing this a heck of a long time and been in a lot of legislative sessions and spoken with a lot of lawmakers and studied a lot of health policy.
And you've seen a
Uh,
lot of how it works. You've seen the good that can be done with this. You've just told a fantastic story about that.
yeah.
Yeah, I anticipate that stories like that will get fewer and fewer, though, as this legislation goes through, if it gets passed. And it's who knows what's likely to happen to it in the Senate.
Right.
Once the powers that be get wind that they can put the lid on this, that they can really put the kibosh on this, I think this may just be a step in the wrong direction. We may see a whole lot more regulation come down if and when this goes to the Senate. So,
Right.
I
So
really,
just again, if you're keeping score at home, the bill on this one is House Resolution 6317, and it's coming out of Ways and Means. Keep an eye on it and see where this goes. But now, if you want to see this grow, or this movement grow, then you got to see that bill majorly fixed or majorly go away.
yeah, let's have it go away. Let's just have it
Yeah.
go away. Get
Now,
back to that one
if
page.
it goes away, it's going to set back DPC and HSAs for a decade. But
that's
frankly,
better than what
a decade of status quo
is
better
yeah.
than this damage that can be introduced by poorly written legislation that had not been vetted by people that was sort of rammed through with you've got to pass this or nothing's going to happen for 10 years.
Yeah,
You know
tailored
what?
to.
Then let nothing happen for 10 years and we'll take our chances
Yeah,
on
yeah,
that.
yeah. Let's not cater to the special interests
Yeah.
and doom everyone else. Well, thank you so much for your time tonight. I really appreciate it, Dr. Gross. And
Thank you for yours. Thank you for your continued efforts.
I appreciate it. No, thank you. You're the one traveling all over the place and attending legislative meetings, so keep that up, and I'll see if I can help out as well. Why don't you give us your information one more time? Give us your website.
Yeah, so the best place to find more information is go to Docs for Patient Care Foundation. That's www.d4pcfoundation.org. We're holding a direct primary care conference in Orlando, November 1st to November 3rd. This is a conference where we bring physicians from all around the country to teach them how to set up DPC practices.
Great.
We are nearly selling out. There's going to be about 350 physicians at this conference this year. This is our third annual conference. So we're looking forward to it. Should be well attended, and we're looking forward to excitement and expanding this model even further.
Well, patients ought to as well, so let's get the word out. And I appreciate your time. Thanks again, Dr. Gross, and thanks everybody for tuning in to Healthcare-onomics.
Thank you.